Good morning. When we have to deal with an ovarian cyst, obviously our primary aim is to diagnose ovarian cancer as soon as possible. However, we may have other secondary aims, including assessing whether surgery is required and understanding if a conservative management of the cyst is feasible. It is important to understand who will have to operate the patient in the case surgery is required. Therefore, if the surgical procedure can be performed by a general gynecologist, a gynecological oncologist, or if even a multidisciplinary team is required, we will have to understand which type of surgery can be offered to the patient, therefore laparotomy or minimal invasive surgery. We may try to understand whether surgical session will be required at the time of surgery. And finally, we will have to plan the surgical strategy, therefore understand whether the patient will undergo primary debulking surgery versus a two-step surgery, or whether a fertility-sparing approach can be considered. In this perspective, several imaging techniques have been used over the years to assess ovarian masses. And these techniques include computerized tomography, magnetic resonance imaging, positron emission tomography, and ultrasonography. However, it is now well established that ultrasonography is the first-line investigation for the assessment of adnexal masses. And this statement is mainly based on the work that was done by the IOTA group. This is the historical consensus published over 20 years ago that defined how to measure ovarian masses and which term must be used to define the different type of cyst. Using a standardized method to evaluate adnexal masses has several advantages because it allows to understand each other, it facilitates the training, it allows to use diagnostic models, and it allows to ask a second opinion. Finally, it is also useful from a scientific point of view because it allows to compare scientific study, perform meta-analysis, and organize multi-center trials. Concerning the type of tumors, we have 5 different types of adnexal tumors. First of all, the unilocular cyst, which is a cyst with one locule, no septa, and no solid component, and the unilocular solid cyst, which is a cyst with one locule with a solid component that can be a papillary projection or some other type of solid component. Then we have the multilocular cyst, which contain septa but not a solid component, and it must be observed that even a bilocular cyst must be classified as multilocular. Then we have the multilocular solid cyst, which contain both septa and the solid component. And finally, we will have the solid mass, which consists of a list of 80% of solid tissue. In this case, you must scan the lesion and estimate the percentage of solid tissue. Using this classification of the type of cyst, it is already possible to estimate the risk of malignancy. In fact, while the risk is very low for unilocular cyst, less than 1%, it rises to 33% in case of unilocular solid cyst. It is 10% in case of multilocular cyst. It is 41% in case of multilocular solid cyst, and it is over 60% in case of solid tumors. The solid component of an adnexal mass has a structure that has a echogenicity that is suggestive of a tissue, such as the myometrium, the ovarian stroma, and all the tissue potentially are vascularized. It is important to observe that the white ball that can be present in a dermoid cyst must not be considered solid tissue. Similarly, sometimes it may be difficult to discriminate the solid tissue from amorphous material that can be present within the cyst. However, there are some tricks that can help in identifying solid tissue. First of all, you can push with the probe on the mass, and you will observe that if the mass is a clot and not solid tissue, it will lift away from the cyst wall. Also, another relevant fact is that the clot will not be vascularized, in contrast to the solid tissue. An important definition is the papillary projection, which is a protrusion of a solid tissue into the cyst cavity with a height of at least 3 millimeters. The protrusion of a solid tissue of less than 3 millimeter height must be considered simply an irregularity of the cyst wall, and therefore it is not a papillary projection. We must observe that all papillary projections are a solid component, although not all solid components are a papillary projection, obviously. And you can see two videos of a papillary projection on the left and on the right, the vascularization. Concerning the content of the cyst, we may recognize an anechoic content, a low-level content, the typical ground glass content that is present in ovarian endometrioma, the hemorrhagic content, and the mixed content that can be observed in dermoid cyst. Concerning the external surface of the mass, we can observe that it is regular or that it is irregular, as shown in the video below. When we wanted to measure a cyst or a solid component, we must always perform a standardized measurement in the 3 orthogonal diameter, as you can see in the two images in this slide, of a cyst on the bottom and on the top, and of a solid component on the bottom. Another relevant definition is the septum. The complete septum is a thin strand of tissue that runs from one internal surface to another. The incomplete septum is a thin strand of tissue that does not reach the opposite wall of the cystic structure in some scanning planes. An important aspect of the adnexal masses is the color score that is based on a subjective evaluation of the color content of the tumor. And in particular, in a color score 1, we have no detectable color Doppler signal. In a color score 2, we have a minimal amount of color Doppler signal. In color score 3, we have moderate amount of color Doppler signal, and in color score 4, we have abundant amount of color Doppler signal. Obviously, it is important to adjust the Doppler setting in order to maximize the detection of the float without creating artifacts. We must remember that color score 4 is not only typical of malignancy, but also of normal functional ovarian cyst, such as an hemorrhagic corpus luteum or a common corpus luteum. And this is important because it demonstrates that we cannot rely on a single feature of the cyst, and we always need to compare multiple parameters in order to obtain a more reliable classification. Also, we need to evaluate the presence of ascites, which is defined as the presence of fluid outside the pouch of Douglas. And we must be aware on how to perform the measurement of papillary projection. We must measure the largest papillary projection. Ideally, we must perform the measurement in 3 orthogonal planes. And when assessing the height of the projection, we must not include the cyst wall or the septum. An important aspect of this presentation is the simple rules that was proposed by the IOTA group. In particular, in this historical paper, 5 rules predicting malignancy and 5 rules predicting benign ovarian tumors were defined. And what is relevant is that if one or more malignant rules apply to a cyst, in the absence of a benign rule, the masses must be classified as malignant. If one or more benign rule apply to the cyst in the absence of a malignant rule, the mass can be considered benign. And if both malignant and benign rules apply, the mass cannot be classified. And if no rules apply, the mass cannot be classified. And here we have the benign rules. B1 is unilocular cyst. B2 is a solid component with height of less than 7 millimeters. B3 is the presence of acoustic shadows. B4 is smooth multilocular tumor with largest diameter of less than 10 centimeters. And B5 is color score 1, absence of vascularization. In contrast, considering malignant rule, M1 is irregular solid tumor, M2 is presence of ascites, M3 is presence of at least 4 papillary structure, and finally, M4 is irregular multilocular solid tumor with largest diameter of more than 10 centimeters. Finally, M5 is abundant vascularization, color score 4. When using these simple rules, we can obtain a sensibility of 93% and a specificity of 90%. However, simple rules can be applicated only to approximately 75% of the ovarian masses, and therefore in 25% of the cases, we do not have a conclusive result. Therefore, we must ask the opinion of an expert, or alternatively, we can use the adnexal model. In a subsequent publication, the IOTA group tried to classify the risk of malignancy of an ovarian cyst depending on the number of benign and malignant features that were detected in a specific cyst. And for example, when we have no malignant features and more than 2 benign features, the risk of malignancy is very low, less than 3%, 0.3%. In contrast, when we have more malignant than benign feature present, the risk of malignancy is between 42 and 99.9%. Thus, it is a very high risk. In this meta-analysis that included 47 articles and approximately 20,000 adnexal tumors, the IOTA method was found to be very effective as a diagnostic performance, in particularly when compared with the risk malignancy index 1, 2, and 3. A further advantage that we have when detecting, when studying ovarian masses is the adnexal model. The adnexal is a mathematical model that was designed to predict the risk of malignancy in adnexal lesion. It not only distinguishes between benign and malignant lesion, but also it gives an individualized risk of malignancy in terms of borderline tumors, invasive cancer, and metastatic lesions. Here you can see the variables that are considered in the adnexal model. We have 3 clinical variables: the age of the patient, the fact that the assessment is performed in an oncological center, and then an optional data that is the measurement of CA1 to 5. And then we have 6 ultrasonographic variables that are the maximum diameter of the lesion, the maximum diameter of the solid component of the lesions, the presence of more than 10 cyst locus, the number of population, the presence of acoustic shades, and the presence of ascites. And here you can see that depending on the cutoff that is used, the sensitivity and the specificity of the adnexal will change. For example, if we choose a very low cutoff, for instance, 1%, the sensitivity will be very high, 99.7%, but the specificity will drop to 17%. In contrast, it seems more reasonable to choose a cutoff of approximately 20%. With this cutoff, the sensitivity dropped to 92%, but it is still quite good, and the specificity is much higher, 81%. Thus, this seems to be a good balance between sensitivity and specificity. When assessing the cyst, we have some descriptors that allows to establish the characteristic of the cyst. And in particular, we have 4 benign descriptors that are all observed in unilocular cyst. And we have also 2 malignant descriptors. One is a tumor with ascites and at least a moderate amount of color Doppler signal in postmenopausal female. And the other is age over 50 years and CA125 over 100. Here you can see the simple descriptor 1, which is a unilocular cyst with ground glass echogenicity and largest diameter of less than 10 centimeters in a premenopausal woman, which correspond to the endometrioma. Here you can see simple descriptor 2, which is a unilocular cyst with mixed echogenicity, acoustic shadows, and largest diameter of less than 10 centimeters in a premenopausal woman, and this is a dermoid cyst. Then we have a simple descriptor 3 that is a unilocular cyst with anechoic cyst fluid, smooth internal walls, and largest diameter of less than 10 centimeters in a pre- or postmenopausal woman. This is a simple cyst or a cystoadenoma. Then we have a simple descriptor 4, which are all the other unilocular cysts with a smooth internal wall and largest diameter of less than 10 centimeters in pre- or for a postmenopausal woman, for example, an hemorrhagic cyst. In the two-step strategy, what is suggested is to use the easy descriptor, and if we cannot classify the cyst based on this, it is advisable to use the adnexal model. In this study, a comparison was performed between the adnex and other methods used to classify the ovarian masses, and the risk of malignancy index was found to be the least accurate method. The adnex had an optimal cutoff at 26.1%, with a sensitivity of 0.9 and a specificity of 0.76. Only subjective appearance by an expert was superior to the adnex. In conclusion, when dealing with an adnexal mass, it is important to describe the mass using the iota terminology. Using the simple descriptor, we can approximately classify 50% of the cases. And using the simple rules, we can classify approximately 75% of the adnexal masses. However, simple rules are inconclusive in 75% of the cases. And in these cases, we may use the adnex model, which is almost as good as having an expert in your clinic. Thank you for your attention.